Okay, let's see. So sorry, I forgot to say something. Happy birthday. It's not my birthday. I don't know who. Oh, not me. Okay, get rid of that. Just, I don't know. That's a very late happy birthday wish. Does tragus piercing actually help with migraine? I have no idea. Does it? Does anyone know?
My dad happens to. He has one, and he's like, yeah, my migraine is gone.
Really? Interesting. Is there any special piercing or like any material?
What?
Any like special material, like maybe some?
It's just, he literally went to an atomic tattoo and got it done.
So now an N of 2, so 50% effective. Interesting. Maybe there's something to it. Boy, if I had the time to share piercing stories with you guys. But let's see. One of the old neurologists I used to work under would instruct patients to take magnesium prior to starting anti-migraine prescriptions. Have you heard anything about it? She wasn't sure why it worked, but it just said that it worked. So there's something. So magnesium itself tends to be a smooth muscle relaxing agent. So if you recall, briefly when we were talking about like status asthmaticus, remember we would give magnesium to those patients because it helped with bronchodilation. So perhaps using that magnesium, because it kind of works a little bit like the body's natural calcium channel blocker. Maybe there's something to helping to stabilize those vessels, so maybe they don't dilate out. Or maybe it kind of helps regulate it a little bit. That's me guessing. I have no idea. There may be some papers out there, but I do not know. But could it hurt? I don't know. Probably not. It's magnesium. It's water soluble, so probably not too big of an issue there. Anyway, any other questions before I get going? No. Okay. We have 62 individuals. We should try getting different piercings on everyone to see what type of health effects occurs. So anyway. Let's see here. So we're going to talk about GI. I'm not going to forget to do that. Okay, so we'll start with GERD. We'll start at the top a little bit and work our way down. So what is GERD? Gastroesophageal reflux disease. What does that mean, though?
Reflux.
Reflux of?
The gastric to the esophagus.
Okay, so what kind of contents are we refluxing? Acid, right? So, but the stomach's okay with that acid, right? Why is it not good for the esophagus? Yeah, it doesn't have the same kind of protective barriers that the stomach will have. We'll look at the different factors that go into that because that'll be really important for understanding how the meds are going to be working here as well. So anyway, so we have this abnormal, and it can occur for a lot of different reasons, right? What are some reasons why we would have GERD? So it could be related to, say, that lower esophageal sphincter. Perhaps it wasn't closing off enough, right? So again, I always talk about sphincter tone in terms of how worried you should be about something, but this is another case where sphincter tone too low could cause reflux to happen, right? It's one thing. If you're having too much content in the stomach, that could cause reflux to occur, right? If you just had to go back for that third plate at the Golden Corral, could be some reflux happening there, right? Tight clothing, you have secretory disorders, a lot of different reasons for this occurring. And we'll look at some of the ways we can actually help with that, right? And again, the esophagus just isn't built to handle all those peptic enzymes and bile acids and all that kind of stuff. And so you'll find that over time it will cause that damage to the tissue. What are some of the really bad kind of consequences of that? Cancer is a big one, right? So you can have esophageal cancer just because you're chronically sort of degrading that tissue and those cells are coming back, but they can have mutations over time. They have the dysplasia that develops, eventually developing esophageal cancer. In some cases, you may even have things like esophageal perforations that can occur, all kinds of bad things there, right? So anyway, and so we'll look at different ways we can manage this, right? So we have things that where if you're having poor gastric emptying, maybe due to, say, diabetes, right? You're getting gastroparesis, and that's causing your GERD symptoms. We have meds that can help propel things along. We have prokinetic agents. We have things that decrease the amount of acid you produce, or maybe things that actually neutralize acid as it is produced, right? So we'll look at some different ways we can actually manage this. In some cases, you may need surgical options, right? We have a lot of kids who have issues where they have to have a Nissen procedure, where they actually will have that lower esophageal sphincter strengthened through a surgical procedure that helps that out. So a lot of different factors here. So looking at the actual cells within the stomach itself, so we have two main ones we're going to be referring to. There's another one we'll look at in terms of gastric protection, but in terms of acid production here, we're going to look at our paracrine cell and then our parietal cells. So H here would stand for what? What?
Histamine.
Histamine, very good. Glad no one said heroin. But histamine, yes. So histamine is going to be a big player here, right? Because what's a big group of drugs we use for our GERD symptoms? H2 blockers, right? So we're going to see histamine is going to be a big component here. Histamine is important. What other sort of neurotransmitters here might be playing a role? What does M stand for, you think? It's a muscarinic receptor, which is going to respond to acetylcholine. Very good. So we know that when we have our remember our rest and digest nervous system, the parasympathetic nervous system, remember that kicks off even before there's food in the stomach there. If you remember, there's sort of a the brain will kind of trigger off a lot of that stuff just by seeing food, right? If you see that big juicy hamburger, if that is the food of your choice, all of a sudden you start salivating and your stomach starts getting started up by releasing things like acetylcholine from that parasympathetic nervous system. So that's a big one. We'll see gastrin is also going to be playing a big role here as well to stimulate acid production. And then we see prostaglandins here too. So prostaglandins are also going to be sort of the other half of that seesaw there. We're going to find prostaglandins tend to inhibit production of gastric acid, and we'll see why that's important as well with certain medications that can cause some issues here, as we will see. Ultimately, what you're going to find is that either through gastrin or through acetylcholine or through histamine is going to stimulate this proton pump here. Right, and I'm sure we've all heard of PPIs before, proton pump inhibitors. So it's another really important drug target as well. Basically, we're going to be shooting out hydrogen ions, and that's going to do what to the pH of the stomach? Decrease it to about a level of what? About 2, yeah. So I always think about 2 as being kind of the typical number. And again, we have ways to protect our stomach from that really acidic material, but the esophagus does not, which is why we see those problems. So looking at the epithelial cells, you're going to find that here we have two main things. You're going to be stimulating release of mucus, which I misspelled, and also bicarb. That combination there is what's going to provide that lining around the stomach that basically keeps our stomach from eating itself, right, from digesting itself. And so here we're going to find prostaglandins are a big one, and then also acetylcholine acting on muscarinic receptors. I don't care if you know if it's an M1 or an M3, just know that acetylcholine works on muscarinic receptors to stimulate this process, right? So what would happen, say, if I got rid of prostaglandins? You'll lose that barrier, and then you can have things like peptic ulcers develop as you start to chew through the stomach there. Anything that gets rid of prostaglandins? NSAIDs, what else? Corticosteroids, right? Anything decreasing prostaglandin synthesis, a lot of anti-inflammatories will do this. So we're going to see already where some of our drug interactions can come into here, or drug-induced causes for some of the issues. And again, it's a pretty good barrier. It's able to keep the pH there around 7 or so. It's able to neutralize a lot of those acids as they get into it and prevent the actual tissue of the stomach from being digested. So other risk factors, we see that, a lot of different factors go into this. Some of it could just be physical location. It could be physical size. It could be a lot of different things. Pregnancy, unfortunately, cause a lot of this. Why do you think pregnant women get more GERD symptoms? There's this thing in their uterus that is pushing everything up, and so it's very uncomfortable, and so they can get a lot of those GERD symptoms because of that, right? Alcohol use, smoking, again, like you mentioned, the Golden Corral is probably the #1 cause for GERD symptoms in the I'm just kidding, I have no data to back that up. Certain foods will do it too, certain spicy foods, and whatever a patient is going to be, their particular triggers happen to be. So looking at certain foods that can do this, again, it's all the good stuff in life. So, like fried and fatty foods and alcohol. I mean, that's like half my weekend right there. Just kidding. Citrus, any of this kind of highly acidic in and of itself could also be triggering this as well. But I want to look at the medications that can lead to GERD symptoms, because frequently a patient comes in complaining of GERD. Your thing you would want to do is say, well, let's treat this with medications. Well, frequently, if it's the medication is causing a problem in the first place, something else they're on, well, maybe either decreasing a dose or changing to something else can be beneficial there, right? So things like anticholinergics and narcotics, and specifically, I mean, opioids. Why do you think that could lead to GERD symptoms? Yeah, they kind of decrease peristalsis. So things are not moving along. They're just going to kind of sit there, and that can eventually lead to that reflux occurring there, right? Calcium channel blockers, right? What was a big side effect we saw of a lot of calcium channel blockers? Constipation, right? Because you're blocking that smooth muscle from contracting. Again, similar thing there. You're decreasing peristalsis, things get backed up, and eventually back up into the esophagus, right? How about nitrates? Why would that cause an issue? Because nitrates dilate smooth muscle, right? Just like we see in the coronary vessels, it can do the same thing to the lower esophageal sphincter. It can actually directly loosen that muscle such that you can have more likely for things to reflux back. Bisphosphonates, we'll talk about that when we get in. Anyone know what we use bisphosphonates for? Yeah, there's going to be osteoporosis. There's going to be things like your alendronate and ibandronate and things like that. Those ones are kind of interesting. They actually will get lodged into the esophagus, and they actually just cause a lot of irritation. So sometimes it has to do with actually how the patients are taking the medications. You have to have very specific instructions on how they take those to prevent that. We'll talk about that later on. I think in the rheumatology section we'll get to that. But certain things like iron salts, potassium salts, they can all cause a lot of irritation in the esophagus. And then aspirin and NSAIDs, well, as we'll see in just a little bit, mainly due to a lot of their prostaglandin effects. So what are our goals in GERD therapy? Well, obviously, if we can eliminate symptoms, that's going to be ideal. Fewer episodes. And then if they have sort of injured mucosa, we want to be able to heal that up. And so we'll look at some ways we can do that by affecting the acid production or the acid that's already there. So obviously treatment options, lifestyle modifications obviously be the biggest one. So again, if it has to do with their dietary issues or if they're smoking or things like that, try to get them to change that if possible. Not always going to be a safe bet though. And so then we're going to look at some of the pharmacological interventions. Mentioned there is some surgical options that are there, but again, we're not going to get into that because I don't know a whole lot about surgery beyond what I've already told you. So getting into lifestyle mods, we can do things like weight loss, things like for recumbencies and issues. So just with the laying the patient down, if that's allowing the reflux to occur, sitting them up a little bit is going to help with that. Avoid tight-fitting clothing, all those things there. So, and then if it has to do with medication, make sure they're taking with plenty of water. Some people try to take medications just dry, and that may be leading to them getting stuck in the esophagus, and that can be a problem too. So our pharmacologic options for GERD, what I don't really want to get to. So we're going to look at our antacids. We're going to look at our H2 antagonist. We'll look at our proton pump inhibitors, and then we'll have some miscellaneous agents with our prokinetic drugs and then mucosal protectants. So kind of getting into it. So what's our basis for therapy? It's kind of three modes that we can go into in order to treat our GERD symptoms. One, we can neutralize the excess acid that's already there, right? So what do you think is going to do this? A base, yeah, we were going to use a base, which is going to be our antacids, right? So we're going to find by using basic drugs. They're not so complex, but they're pretty basic. They can go ahead and neutralize that acid. We can do things to decrease the actual amount of acid we're producing in the first place, or we can try to basically beef up the mucosal barrier that's already there, right? Especially if it's lacking because of maybe drugs that we're giving the patient or something like that. So, as I mentioned, antacids are going to be neutralizing the excess acid, and I'll show you the different ones we use here. And you're going to find that they differ based on things like their neutralizing capacity. Some are better than others. You're going to find they may have different solubility, and palatability is going to be the other thing as well that comes into this. So, the agents we have, what's this one right here, this top one? Sodium bicarb, right? So it's just baking soda basically. If you combine this with the stomach acids, guess what you produce? Sodium chloride, H2O, and CO2, right? So can you see any problems with this? Well, what happens to all that extra sodium you're producing there? Patient absorbs it. Maybe what can that worsen? Hypertension potentially, right? So you already see some issues here. How about that CO2? What does that do? All that extra gas is being formed. It's got to come out somewhere, right? Usually, you know the special name for that? Not belching, something even more fancy than that. Is an eructation? Yes. I heard someone else say that. Eructation? Eructation, that's my fancy word for the day for you fine folks. So there's that. You have calcium carbonate, right? Does anyone know another name for this one? The typical over-the-counter drug name for this? Tums, right? So this is going to be your bread and butter. Most patients will have had at least taken Tums at some point in their life. You can see here, you get calcium chloride being formed. Again, they get similar CO2 that's being formed here. Even at things like, what's this? It's aluminum hydroxide, right? So thinking aluminum, like, what's a normal blood level of aluminum? hopefully 0, right? It's not a normally occurring substance in our body there, but we can use aluminum-based products. We'll look at some potential problems with that. And then finally, this last one here, we have magnesium hydroxide, which can also be. So those are kind of the common ones you're going to run into. Far and away, though, you're going to find that calcium carbonate is probably the most common, and then usually a combination of magnesium and aluminum hydroxide together are going to be the second most common. We'll look at why we combine those two in just a moment. So, as I mentioned, sodium bicarbonate, just baking soda, it works pretty quickly, but again, you have to be worried about that sodium load, which can lead to things like the fluid retention. Is probably not great for pregnant patients who already have increased fluid load anyway, which can worsen their hypertension. Patients who are hypernatremic, not great. But again, be aware of that gas production that happens there as well, right? That could be one of the symptoms they're already experiencing when they have GERD, and that can make that worse, right? A lot of belching associated with that. Now, this is an interesting feature, the antacids here, the increased pH, right? Because presumably by giving the antacid, you'd increase the pH within the stomach. It increases gastrin release. Remember, having a higher than normal pH in the stomach stimulates gastrin production, and gastrin does what? Makes more acid, right? It's part of that negative feedback loop. So by introducing an antacid, you disrupt the negative feedback loop, and then you produce more gastrin to get that pH back down. So overall, the efficacy is going to be somewhat limited, right? You're kind of shooting yourself in the foot a little bit, because by increasing the pH, you just get more acid being produced. So these are not going to be good for sort of chronic therapy, but these are good for sort of acute bouts, right? So if you just had a big dinner and you're feeling a little bit of GERD, this is good for that, right? Or if you can predict when you're going to have GERD symptoms, this is good to use for those. So, intermittent use as needed, not going to be around the clock typically, okay? That's going to be in general for all the antacids here. Calcium carbonate is going to work pretty rapidly well, kind of moderate neutralizing capability. They will absorb some calcium, and who might that be good for? Postmenopausal patients, really anyone, any elderly patients, osteoporosis and not just a disease of females, men can get it too. That can be beneficial. However, what happens to all that extra calcium potentially? Same things like kidney stones that can develop, right? Especially if they have a history of that. So you do need to be wary of that, because not only are you going to alkalize the contents of the stomach, but you could alkalize a little bit to some degree things like the kidneys, right? And so that increased pH decreases the solubility of calcium, as you find there. And again, be aware of that increased gastrin secretion, so again, self-limited in terms of how effective it's going to be in the long term. Constipation is going to be a big one you're going to see with this, right? Calcium-containing products typically cause constipation, so be aware. If patients are already on things like opioids or a calcium channel blocker, calcium tends to worsen that. Again, not great for patients who already are constipated. Is constipation a big thing in the U.S.? We don't get enough fiber in our diet. I was just reading a whole thing about potty training kids, and they're saying that you want to make sure that their poop is kind of like the consistency of like mashed sweet potatoes or hummus, and that way your kids are not constipated. And if it's anything other than that, they're not ready for it. There's a lot of holding issues that happen. It's actually an article by a pediatric urologist, and it was pretty interesting. Only because I'm in that situation, right? It's not interesting for anyone else, but yeah, constipation is a chronic thing because we have typically a low fiber diet here in the U.S., right? Okay. Next, we have aluminum hydroxide. By itself, this is typically called Amphagel. Typically, we would use this by itself for patients who have chronic kidney disease, and we'll talk about that towards the end of the class this semester here. But it works for patients with chronic kidney disease because they typically have an issue with too much calcium and too much phosphate in their system because they can't process it because the kidneys are not working as well. So this is actually a phosphate binder, typically by itself. So you'll give it with meals, you bind up phosphate and prevent it from being absorbed. Basically, it's insoluble once it gets bound up in aluminum. However, you can use it as an antacid as well, and you find that not only will it have neutralizing effects with the acid, but also will have a little bit of cytoprotective effects on the mucosa. It kind of helps strengthen that barrier a little bit, as you'll see there. This one is also going to be constipating though, so be aware of that. You typically will find that these also will chelate other drugs, and chelation just means what? It's going to bind them up, right? So you got to be really careful. Typically, antacids you don't want to give along with their other medications, right? Either take other medications like 30 minutes before, or typically say 3 to 4 hours after the antacids, because you worry about them being bound up and not working as effectively. Okay, have seen some issues of aluminum-based products causing appendicitis in some patients, that would be contraindicated. Wouldn't want to worsen that necessarily. And then magnesium hydroxide This is otherwise known as milk of magnesia, if you ever see that. This has a good neutralizing capability. You will find that it does cause diarrhea, though. So, again, sometimes when you give this combination, say I'm going to give aluminum hydroxide, which is constipating, and I'll give it along with magnesium hydroxide, which causes diarrhea. They balance each other out, right? So if you ever see like a Malox or a Myelanta, it is typically a combination of these two antacids there. However, we can give milk of magnesia by itself, and actually if you have a patient who is constipated, you can give them milk of magnesia, and that's going to be a good, we'll call it an osmotic laxative that we'll talk about later. Usually it comes in like in a big green bottle that is, it's carbonated. We call that the green rocket. We know I call it the green rocket as a laxative, because you drink it and then all of a sudden you're going to be shooting off like a rocket to the bathroom. So that's where it gets that name from. Again, we would not want to give this to patients with intestinal obstructions or any kind of issues like that, because again, you can just worsen that. Example is kind of prokinetic sort of force building up, and you have an obstruction there. It's not going to make things any better. And then be careful with renal patients, because they typically cannot process their magnesium anyway, so they might be hypermagnesiemic to begin with. So, as I mentioned, we often will mix magnesium and aluminum hydroxide together to common brand names are Myelanta or Malox. You're going to find that used together, they counteract one another's GI motility effect, so it should be fairly neutral between the two there. Also, it's nice as a liquid medication because of those cytoprotective effects of the aluminum. It nicely coats the stomach and kind of helps to kind of give that tissue there a rest a little bit and kind of beef up that protective barrier a little bit. Typically, liquids are going to be a little bit faster onset because they don't have to dissolve, and they kind of coat a little bit better than the tablets will. So beware of that. So all these ones that we've already mentioned, are they over the counter? Are they prescription only? Most of them are over the counter, right? The aluminum hydroxide by itself is actually a prescription product. All the other ones, though, especially that combination, are all going to be over-the-counter products. So patients who have GERD symptoms, they may try to self-treat themselves. They may not realize they actually have a worse condition than what they think underlying it, right? So if they have a nice peptic ulcer they're nursing, they're just kind of self-treating. They may not realize that. And so that's why it's really important when you look on those on the boxes and things like that, they'll say don't use more than 2 weeks. Go see a healthcare provider, because if you're still having those kind of symptoms, if still that severe, you probably got something else going on, you need to get worked up, right? So in terms of pregnancy, these are all fairly safe. Again, I would probably avoid sodium bicarb just because you can worsen pregnancy-related hypertension, so I'd avoid that. And in terms of drug interactions, again, be very wary because these can all bind up your other drugs. So specifically things like iron products, fluoroquinolones, tetracycline, etc. Right? Okay. Alginic acid is kind of a brief one we'll mention here. Sometimes you'll see this used in combination with things like sodium bicarb, and actually when it combines with that, it forms a very kind of viscous solution that will kind of coat the stomach and again provide that nice cytoprotective sort of effect there. Frequently, if you ever hear like Gaviscon, that's a combination of alginic acid plus sodium bicarb plus some other antacid typically, and again, it can be used, again, it's over the counter, questionable efficacy, but you may see it occasionally. So, as I mentioned, the advantages of the antacids are one, they are pretty rapid in terms of their actions. They're relatively inexpensive, and most of them are available over the counter. So they're good for breakthrough use, but not great for chronic use because, again, of the gastrin issue that we mentioned earlier there. Also, you have to dose them pretty frequently because, again, once they lose that neutralizing capability, they're kind of ineffective at that point. So they kind of wear themselves out pretty quickly there. And again, be wary if you're giving something that's going to cause constipation or diarrhea if your patient already has issues with that to begin with. Okay, so moving next, we're going to go down into reducing the actual gastric acid secretions. We have several ways that we can do this. So first of which we're going to talk about is going to be the H2 receptor antagonist. This is the older of the two groups we're going to look at here. PPI is a little bit newer as they came out after the H2 antagonist. And essentially by blocking the H2 receptor here, you'll still have things like gastrin that can stimulate gastric acid production. You'll still have things like acetylcholine that can do that, but you take away a pretty major sort of mediator here by blocking that. So you should see decreased acid production because of PPI, proton pumps not going to be working as excessively. And you're going to find that overall throughout the day, whether it be daytime, nighttime, etc., that you're going to find decreased acid production, right? So it doesn't do anything to neutralize the acids already there. So it may not be good for sort of acute treatment as well as an antacid might be, but better for sort of around-the-clock chronic management for sure. Okay. So, and actually, a lot of these are structural analogs of histamines. They kind of look like it. They usually have some kind of bulky side chain, so that way it doesn't actually interact. It blocks the receptor, but it doesn't activate it itself. And there's 4 that we have here. Most of these have an IV counterpart as well, which is nice. All these are available over the counter orally. We have some IV candidates as well, things like IV ranitidine and famotidine, which are nice for inpatient use for sure. But we have 4, cimetidine, ranitidine, which is Zantac, famotidine is Pepcid, and then nizatidine is Acid. There's one here I will tell you never ever recommend or tell anyone to ever use, cimetidine. Anyone know why?
Tons of side effects.
Not tons of side effects. It's a potent CYP3A4 inhibitor. And it's a PGP inhibitor too. Remember, PGP is that efflux pump we mentioned there. So you can see pretty drastic increases in levels of medications because of that. So I never ever recommend it. And in fact, there was a lady one time I was doing a rotation it's actually an out-of-state poison center, and we were in the hospital, and this lady had overdosed on a drug. We'll talk about one a little bit later on. It's an antidiarrheal drug called loperamide. And loperamide itself is an opioid, but it doesn't really cause a lot of euphoric effects because the PGP pumps in the blood-brain barrier will spit it back out so quickly that you don't really get any up into the brain. So it's good as an antidiarrheal, but it doesn't cause any euphoric effects unless you inhibit those pumps. So what did this lady do? She must have looked it up online somewhere. Someone recommended, well, if you take cimetidine, which I can get from any pharmacy, along with a lot of loperamide, which I can get from any pharmacy, guess what? All that loperamide ends up in the brain. Think she had a good time with this? No, because we were dealing with her in the ICU when she was in, she went to torsades and had all kinds of other issues, nearly died, but she eventually came out of it. But she was harnessing a drug interaction for her own purposes. And again, just goes to show you that even though it's over the counter, doesn't mean the stuff is safe. So cimetidine, never ever recommend due to CYP3A4 and PGP inhibition, okay? Anyway, they'll work pretty well. They do have renal elimination, so you do have to watch out for that. Make sure patients have pretty significant renal dysfunction. You do need to adjust your dose a little bit. Otherwise, these drugs are very well tolerated, so you don't really see a ton of side effects from them, and so they oftentimes get missed in terms of that renal dose adjustment. So you do want to be wary of that. Now, these are things that happen extremely rarely. I can count on 0 hands the number of times I've seen a side effect due to one of these medications, but you never know. You may find that one patient who develops thrombocytopenia due to famotidine, but it'd be very hard to pinpoint as that being the particular cause for it. But just know, very, very well tolerated. Now, these will be effective in a lot of patients, and you'll find that they definitely are more effective in terms of antacids, mainly because they're going to be able to work sort of around the clock. So most of the time, these are going to be scheduled medications. Most of the time, your antacids are going to be more as needed sort of basis, right? And so the reason why I pick one versus the other typically has to do with cost, or it may have to do with availability. So for instance, like at Nemours, we used IV ranitidine as our go-to H2 blocker for a long time until a shortage happened, and then we couldn't get access to it anymore. So then we switched over to famotidine and never really switched back, right? So a lot of it can be based on things like that, because you may be working in a hospital or something, and they say, okay, we don't have this drug anymore, we're switching over to this other one. You're like, well, how come? Like, don't they work the same? Like, yeah, but a lot of times it has to do with some of that background stuff like cost or availability, things like that. Recalls, all kinds of things can affect it. These are also very safe in pregnancy, so category B, which means very safe, no documented harm to the fetus. So these would be recommended for pregnant patients if maybe antacids were not a good option for them, or they're having more kind of consistent GERD symptoms. Typically, you see a lot of these dosed twice daily. Again, the half-lives are not such that you can just get away with once daily dosing, but they do provide around-the-clock coverage there. For some patients, though, if they only get nighttime symptoms, when they have the kind of nocturnal sort of increase in gastric acid production, maybe they only take it at nighttime before they go to bed. Just depends on the patient there. Some patients will use it as needed. So say, for instance, they know that like certain types of foods will trigger off their GERD. If they know about that, they can take an H2 blocker beforehand, say 30 minutes, an hour beforehand, and that way that will help prevent their symptoms from occurring. So some patients use it as needed. A lot of patients will do it just scheduled. Okay, as I mentioned, avoid cimetidine, potent 3A4 inhibitor. Up next is our PPIs, or proton pump inhibitors. These are going to be the most potent agents we have at decreasing acid production. So these, because again, you're kind of going straight to the end of the line here, right? So again, if I block histamine receptors, I still have acetylcholine, I still have gastrin that can cause acid to be produced, but what if I just block the receptor entirely? Well, yeah, no acid gets produced at that point, right? And actually, these are going to be irreversible inhibitors, which means that once that pump is inhibited, it's done for. Until your stomach produces a new pump, It's not going to do anything, okay? And actually, you find that up to 95% inhibition of gastric acid is after about 7 days of consistent therapy. So very, very effective at what they do. Very good for like really hyper secretory sort of conditions. Very, very effective. We have 5 in this category here, and some of these are available over the counter now. So for instance, like omeprazole, you can get over the counter. I think maybe lansoprazole you can't. I had to double check. But you have esomeprazole, you have lansoprazole, omeprazole, pantoprazole, and then rabeprazole. Pantoprazole is kind of like your go-to IV one that I see most commonly. I'm not going to ask you on a test, is this available IV or PO? Like, I'm not going to ask that, but just for your reference there. Any of these cousins to one another? Did you notice? Yeah, omeprazole and esomeprazole. So esomeprazole is the enantiomer of omeprazole, right? Again, is there any better efficacy with esomeprazole versus omeprazole? Not that I know of, right? But they got a new patent off of it. Interesting. So necessary. So anyway, so in terms of adverse effects, there's few, but there's some chronic things you can actually run into. So for instance, and I run into this a lot, like say in the ICU sort of setting. So when you have patients who are critically ill, their body's like really stressed out, right? You're producing a tons of cortisol. You may actually run out of cortisol to produce. Say you're ventilated. You're really worried about infection in those kind of patients there, right? But also when you're that stressed out and you're producing all the cortisol, what does it do to your prostaglandin formation? It decreases it, right? Because all the corticosteroids, the cortisol, the hydrocortisone you're producing, is decreasing prostaglandin production. So what happens to that gastric barrier that you have there? It's going to get diminished, right? Just like if you were giving an NSAID or something. So the risk for stress-induced ulcers goes up pretty significantly the more kind of physiologically stressed out you are, especially for over the long period of time. So frequently for stress ulcer prophylaxis, we'll either, and most often, give a PPI, or in some cases give an H2 blocker, but for most patients get a PPI there. And so that's good because now they're not going to get a stress ulcer because they don't have so much acid being produced, and so everything's fine, right? Well, what happens when you increase and elevate the pH of the stomach? Well, normally, does anything grow in the stomach in terms of bacteria? Not unless you're H. pylori, right? So now all of a sudden you have these bacteria that are now able to reproduce, and they can kind of crawl up the esophagus, and then where do they go? Down to the respiratory tract. So you can have these kind of micro aspirations that occur, especially in ventilated patients, and now you have to worry about them getting a ventilator-associated pneumonia based off the fact that now these bugs can grow within the stomach. So kind of a double-edged sword there, right? And so we do things like make sure we have good oral care, make sure we have chlorhexidine swabs and things like that to try to prevent infection. But it's kind of that thing where it's like we know we have to prevent the stress ulcers, but we also have to worry about the infection risk as well. So just something to kind of think about there. Another issue that can happen kind of long-term, which is kind of a theoretical risk, is that calcium absorbs better. It's more soluble in more acidic solutions. So by kind of chronically increasing the pH here, you theoretically can decrease calcium absorption, and that may worsen things like osteoporosis. That'd be one thing to also kind of consider there, okay? So we will find that these drugs only work on active secreting pumps. So when are those pumps most active? When you're eating, right? When you're digesting. So that's why they actually recommend for best efficacy, you can give it 30 minutes before a meal time. So that way by the time it's in the system, those pumps are starting to ramp up to digest whatever you've eaten, and then they can then interact with those pumps and irreversibly inhibit them. So that's where you get the best efficacy there. A lot of these actually come in capsules, and if you were to open up those capsules, they have these little tiny beads inside. Does anyone know why that is? So that's one thought, maybe it disperses better. Not in this case. So what actually happens is that normally acidic solutions will destroy the drug. It actually makes it ineffective. And so what they do is they actually coat it with something, this coating that protects the drug, and it's only going to dissolve when it gets to a more basic solution. So as you take it and it opens up from the capsule in the stomach where the pH is low, it doesn't dissolve, right? So the drug is protected. Once it gets into the small intestine, I guess the duodenum, as some people have said, what happens to the pH? Increases pretty significantly, right? Your pancreas is sending all that bicarb, pH goes up, that coating dissolves, and then all of a sudden, boom, now you have your active drug that can be absorbed and everything's good. So what happens is patients, they crush or chew the drug before they take it. It's going to break that coating, and then it can lead the drug to be ineffective, okay? just something to know. That's why you can look these lists up, and I encourage you to do so. There's always a do not crush and do not chew list of medications. A lot of times they're like controlled release preparations, where if you were to say bite down on them, that just breaks and allows all the drug to come out at once. But in this case here, it actually has to do with protecting the drug from the stomach acid. Kind of make sense? Okay. Typically, you're going to find, especially patients with esophagitis, they have peptic ulcers, things like that. PPIs tend to be more effective just because they are more potent at blocking acid production. So overall, you may find that they're going to have better efficacy. And in fact, in a lot of cases, especially like peptic ulcers, they have shorter treatment times as well with using a PPI versus an H2 blocker, which is beneficial. Typically, though, cost is going to be a little bit higher for these ones here. So just be aware of that as opposed to the H2 blockers. Again, adverse effect-wise, I don't really see many side effects associated with these. These are things that have just been reported, but nothing real too significant. And you can see some interactions, specifically if you have like other CYP3A4 inhibitors, they can sometimes affect them. But even if the levels go up a little bit, I really don't see too many issues with that for the most part. Okay, so, and this is just an example of things we'll recommend from like an OTC perspective. So a lot of times you're going to find that the recommendations on the side of an over-the-counter product are pretty strict and pretty more rigid than what you would tell the patient if you were prescribing it to them specifically. But it's trying to play it safe with the patient, so that way they know when to come in, when to get further evaluation. So for instance, if they're having dysphagia, if they are developing, say, hematemesis, or if they have black tarry stools, they probably should get checked out. They probably shouldn't say, well, that looks a little weird, but I'm just going to keep taking this over-the-counter PPI, right? They can mask some of the symptoms of these conditions to the point where they're doing kind of worse and worse damage to themselves. So by the time they do show up, it's already an emergency, right? So this is why they say things like, hey, if you're having, any kind of like, if you're dizzy and you're sweating, because, what can MI sometimes present as? Indigestion, right? So again, if they're saying these things to try to make sure that patients are not just self-treating themselves, but they notice these kind of warning signs like, boy, my arm sure is getting numb, and must be that curry I ate. Maybe not, right? So maybe the PPI is not going to be able to fix your issue. Maybe you should go to the ER, right? So little things like that. Typically, these are going to be good for, we have a little less evidence for use for these drugs as opposed to, like, say, the H2 blockers. They've been around forever. But, we'll certainly use these in kids. But just be aware, a lot of the recommendations for over-the-counter products will say, hey, don't use these in kids less than 18. Don't use them in people less than 2, things like that. But frequently, the thing is, like, don't use it continuously because you may be masking something more serious. Okay, the random one here, we have octreotide. This is actually going to be a somatostatin analog. And so somatostatin is a normal hormone that we produce. And remember what it does? It's a growth hormone inhibiting hormone. So this is another name for it, is octreotide or somatostatin. This is actually going to be good because this will block basically release of gastrin, or inhibits the effects of gastrin, kind of another ancillary effect that it has there. And so this is good for patients specifically things like Zollinger-Ellison syndrome, which is kind of a hypersecretory condition, gastrinomas, right? So they're producing too much gastrin from a tumor. That can all be effective there. This is a parenteral only agent, so this is only being used like on more the inpatient side there. You may also see it used occasionally for like variceal bleeds, which can happen in certain patients, like liver patients and things like that. I personally use this, not me personally on myself, I use it for patients that actually have a certain type of drug overdose. When we talk about diabetes, there's a certain class of drugs called the sulfonylureas that causes the pancreas to dump out a ton of insulin. This actually prevents that from occurring, so I kind of use this from a tox perspective. So you may see it used for a host of different things, but in this case here, you can use it to block gastrin specifically. Okay, so then we'll talk about a few mucosal protecting agents here. So one, we have colloidal bismuth, or basically Pepto-Bismol. Another name you might see is like bismuth subsalicylate. You see that as the generic name there. And so this one's going to be good because it helps kind of protect the stomach, kind of coats it, will enhance those kind of cytoprotective effects of that bicarb, that mucus is being produced in the stomach there, and actually helps to inhibit pepsin, right? That's going to be good there. Be aware, though, of a couple of things. So one, you're going to find that it will turn the stools kind of black. And what might that be indicative of? We see black tarry stools. It could be upper GI bleed, right? You've digested all the hemoglobin and stuff is coming out black, right? What's the name for that? Melena. One time I saw a student named Melena. I felt very bad for them. I was like, oh, poor thing. I don't think she was named because of that, but I think it was just a coincidence. Other thing though, it does contain salicylates, right? It's bismuth subsalicylate. So that salicylate, who might that be a problem for? Kids. In what case? Ray's syndrome, right? When does Ray's syndrome occur? It's your post-viral, right? So if you had the flu or chickenpox or something like that, or any kind of virus, if you give them aspirin, that can induce Ray's syndromes. That fatty liver encephalopathy that can develop can be fatal if not caught. So this can also trigger that as well. So make sure to avoid using that kids less than 16 for the most part. Unless as long as they don't have any issues of a viral syndrome recently, right? Another interesting thing as well is that typically, kind of going back to your imaging, and again, I don't have a whole lot to contribute in terms of imaging knowledge, but one interesting thing here with Pepto-Bismol is that you can actually tell on a KUB if someone has taken Pepto-Bismol recently. Anyone know why? Anyone know what things are radio-opaque? Iron is one, but why is iron radio-opaque? It's a metal, yeah. So bismuth is a metal as well, and so actually you can see these like little punctate marks kind of throughout the GI tract. And so if you see that, they've probably taken Pepto-Bismol recently. You can ask them about it, and they'll say, "Oh yeah, I took that a couple hours before I came in." You can see the little bits of bismuth kind of all throughout the GI tract. So it's something kind of interesting. Otherwise, you might think like, "What the heck is that? They get like hit with a gun or something recently, or like buckshot or something?" But no, it's just the bismuth. Okay, another one is going to be caraphate or sucralfate. This is another aluminum salt. But basically, it's non-absorbable, and when it mixes with an acid, you put it into an acidic solution, it forms this really kind of tenacious sort of paste. And so you either give us a tablet, most often though a liquid there, and it helps just to nicely coat the stomach, provides a nice extra kind of protection along with that normal gastric barrier you produce there. Again, not recommended commonly, mostly just for like really kind of mild cases of GERD. Not going to be nearly as effective like an H2 blocker or PPI or something like that. Okay. Another one's interesting is called misoprostol. This is actually an analog of PGE1, so this is like a synthetic prostaglandin, and so it will directly stimulate those epithelial cells to produce more mucus and more bicarb there. And so this is frequently given along with NSAIDs because NSAIDs do what? They inhibit prostaglandin synthesis, so it basically kind of counteracts that. Ideally, if you just not give an NSAID, but in some cases it may not be feasible. So, for instance, there's a formulation where we'll actually give misoprostol plus, I believe it's diclofenac, so Arthrotec, and basically that is meant to help provide prostaglandins that the NSAID is going to be inhibiting the production thereof. Right. Be aware though that typically prostaglandins do have a stimulatory effect on the GI tract, so you can see some diarrhea and abdominal cramping. This one's actually contraindicated in pregnancies. Anyone know why? Actually, we use prostaglandins. We'll talk about this in the OB-GYN section, but prostaglandins actually can stimulate contractions of the uterus and can actually help to stimulate, it's called a tocolysis, or it can actually stimulate contractions to get the baby out, right? Well, what would happen if you took this really early on in pregnancy? It will cause an abortion, right? So this is a means of causing a chemical abortion. You might give this along with something like methotrexate or something, and actually can cause a chemical abortion, so to speak. And so that is why that would be contraindicated for pregnant patients, okay? Don't want to cause unnecessary contractions if they don't need it. And in fact, it's kind of interesting, at least to me, that when I was interning, I originally was interning at a hospital up in Jacksonville, but it was a Catholic organization, and they actually didn't even carry this drug at all because of the risk of maybe someone stealing it and using it for an abortion or something. So it's interesting how sometimes like the religious affiliations within an organization can affect like what drugs you carry or what type of foods in the cafeteria, etc. So little things like that you may see like if you're out there on rotations or something. So I don't know if they still do that, but that was, I don't know. I just realized we'll have graduated from pharmacy school 10 years ago this year, which is just awful feeling. But so it was a while ago, so who knows if they still do that or not. Okay, so just to kind of give you a comparison between the different classes here. Again, your antacids are going to be the cheapest, easiest to get a hold of, however, fairly short duration of relief, and okay efficacy, right? H2 blockers are going to be kind of the step up from there. PPIs are going to be kind of the best bang for your buck, right? More expensive, but going to be the most effective. So if you have someone who's got really kind of recurrent chronic GERD issues, PPIs are going to be the best for them. If they have any kind of esophagitis, if they have any kind of peptic ulcer disease, anything like that, PPIs are probably going to be the go-to with H2 blockers as a backup. Just depends on what they have access to. So, and again, based off of the symptomatology, you can start low or you can start a little bit higher depending on their severity of symptoms. And typically, patients have already tried something, right? So they've already tried something at home, they've tried some over-the-counter stuff. So find out what's worked for them, what hasn't. And again, always recommend the lifestyle changes, right? So figure out if there's some commonality with the things that trigger their GERD symptoms. It could be an anatomical thing, or it could just be related to the food they eat. It could be a lot of things. Typically, if they're kind of early on, mild symptoms, over-the-counter stuff is totally fine. Antacids as needed if it's pretty intermittent. And then as you just kind of step it up, right? So if a little bit more moderate symptoms, you can try an H2 blocker. More severe symptoms, definitely a PPI is going to be the one to go with. And it's nice nowadays because PPIs are more available over-the-counter, as we have more of them have come as an over-the-counter drug there. And then typically if they're more refractory than that, that's when you're going to get your GI colleagues involved and look at more interventional sort of therapies for them. So typically, a lot of patients will end up having relapse. So you may be on kind of chronic maintenance therapy with a PPI or an H2 blocker over the long term. A lot of them do relapse, and so in those cases, there just kind of go back to what was working for them before. You don't have to worry about any kind of like withdrawal effects or anything like that. So there's no tapers built in here. But certainly, the more severe the disease, obviously, PPIs are going to be the better option. So, any questions on that? Okay, I am done. So I am going to let you guys go. I mean, me personally, I'm just done, right? So let me see if there's any questions. Oh my goodness, we do have so many questions here. Okay, I said I was done, people. Jeez. Okay, Prevacid is available over the counter. That is lansoprazole, so that is available over the counter too. So there's one there. Is it possible ADE of isoniazid seizures? Yeah, that is true. Anyone know why? I mentioned it a lecture or two ago. It actually blocks the production of GABA. It inhibits the use of pyridoxine. And remember, pyridoxine we give with isoniazid to prevent neuropathy. So kind of keep that association in mind there. Okay. Okay. I heard the FDA recently recalled Zantac because there were cases when it's shown to cause cancer. Do anything about that? Is it bad to tell patients to take it? I'm not aware of that issue specifically, but I think we still give it orally all the time. So maybe there's a certain manufacturer. Sometimes that can even be down to the manufacturing, their process and how they actually produced it. So that could be the issue there. I'm not sure. And someone told me they took milk and magnesia for a whole month to clean out their digestive system because they were normally constipated. Would that be bad for them? Any side effects you might see? A lot of diarrhea, perhaps hypermagnesemia. If you have good kidneys, you should be able to process that through. And maybe just a raw bottom, probably. That's all I know. Okay, if nothing else, I will see you guys next time.